So the background work for this particular study, when I began my PhD, often the first thing that we do is to conduct a systematic literature review. And when I conducted my review of comorbidities in rheumatoid arthritis, this is usually considered one of the bigger questions in the disease. There was a large volume of published materials, but I also found a large variability in study design, quality of methodology, and standardization between studies. So there were really big differences between the different studies on comorbidities. And what I realized was that there was a limited amount of long-term, high-quality population data where all the comorbidities of rheumatoid arthritis were examined before and after diagnosis. And again, just to go over again, what I really noticed was that the research methods that were being used were not adequate. They weren't strong enough to measure causal attribution. So what does that mean when we talk about causal attribution? It means that how certain are we that a comorbidity of RA is actually related to the disease itself? So looking at the literature, we can see that the methods that are being used or were being used weren't, I would say, appropriate to actually make that distinction as to what comorbidities were related to RA and what comorbidities were underlying or occurring irrespective of the disease diagnosis. So we used a longitudinal matched cohort study design, and we included patients who had an RA diagnosis in each year from 1995 until 2015. And what we did was we matched each RA patient to a patient who didn't have RA and was also alive in the same time period. And what was interesting about our match was we actually used two separate control groups, non-RA control groups. The first control group was matched only on age and sex, but the second control group is the really innovative one, because what we did was we matched on age, sex, but also on pre-diagnosis medical history. The reason why we used two control groups was because the use of multiple control groups let us separate the directly attributable comorbidities of RA and the indirectly attributable comorbidities of RA, and also let us separate the underlying age and sex-related conditions that I mentioned before would have occurred irrespective of an RA diagnosis. So there were many findings. Again, it's a complex topic, but to summarize our main findings, we found that the RA patients have more comorbid conditions compared to non-RA patients. And interestingly, these differences were detectable before the diagnosis. The comorbidities peak in the year of diagnosis, but we then see a decrease in comorbidities after diagnosis. In terms of attribution, we found that approximately half of the attributable comorbidities were directly attributable to RA. We also interestingly found that in the pre-diagnosis period, the indirect effects of RA are observable, but the direct effects of RA manifest after the diagnosis. So that's something that we would expect just with an understanding of the disease. We found that most of the comorbidities are low and medium severity. And then the final finding that I'll mention is that we found that RA patients who are diagnosed in later calendar years appear to have less comorbid conditions compared to patients diagnosed in earlier calendar years.